Hello everyone, welcome to another session of next Saviours Essential Question Series. Today we are going to have a discussion on a very important topic, that is peripheral nerve injuries and how the questions can be asked and you have to identify it. So starting with the first question, that a 3-year-old male neonate born via vaginal delivery to a 25-year-old primate presents with the weakness of the right upper limb. So you see, whenever there is a nerve injury associated with the complications related to the pregnancy, as we are going to witness in the question further, like the mother reports a prolonged second stage of labor requiring forceps assisted delivery due to fetal macrosomia. So there is always a possibility that the shoulder might get stuck under the pubis of the mother, and you know that it is found to be associated with the shoulder dystocia. On examination, the neonate exhibit a asymmetric mororeflex with diminished movement of the right arm. The affected limb is held in adduction, internal rotation, and extension at the level of elbow, with the pronation of the forearm and flexion of the wrist. The grasp reflex is intact, but the biceps and the brachioradialis reflexes are absent on the right side. 5 points which are important for you to remember related to the Erb's palsy. Point number 1, that it is the injury to the upper trunk of the brachial plexus. Point number 2, what are the muscles which are affected at the level of the shoulder? There will be weakness of the deltoid supraspinatus resulting in loss of abduction. There will be a weakness of the infraspinatus and teres minor leading to loss of external rotation. As a result of which, the attitude of the limb would be adduction and internal rotation at the level of the shoulder joint. Now, at the level of elbow, there will be weakness in the flexion because of the affection of the biceps and brachialis, and there will be loss of supination because of the affection of the biceps and supinator. So, the forearm would be kept in pronation and elbow in extension, while the wrist and hand, mild wrist flexion weakness, but the grasp remains intact. So this is how the attitude of the limb is going to be, and this attitude is typically known by the name of policeman tip deformity, as you already are aware of. So answer for this question is Erb's palsy. That is point number 2 that you have to remember. Point number 3 is it is associated with good prognosis, and that is the reason why we are expecting that this time they will give you a clinical question and then they will ask you what will be your advice to the mother to resume physiotherapy, and you have to reassure the patient that there is a possibility that the recovery might take around 3 to 6 months in mild cases because it is a tractional injury. Now another thing that they used to ask is the Klumpke's palsy. All of you know that Klumpke's palsy is injury to the lower trunk of the brachial plexus, and there are going to be two features related to this Klumpke's palsy. One is the claw hand and the other one is the Horner syndrome. All of you are aware of what the Horner syndrome is. There will be ptosis, meiosis, anhidrosis, loss of ciliospinal reflex, and enophthalmos. And it is because of the involvement of the T1 sympathetic fibers, because the lower trunk of the brachial plexus is made up of C8T1. Coming on to the next question, a 35-year-old right-handed male construction worker presents to the OPD with a complaint of difficulty in extending the fingers of his right hand for the past 2 weeks. So the moment you see this extension of the fingers, that means somewhere radial nerve related question is asked. So he reports a history of trauma while using a power drill where he experienced a sudden twisting injury to his forearm. Now, since then, he has noticed an inability to extend his fingers at the metacarpophalangeal joint, but he can still extend the wrist with some weakness. So he denies any sensory loss or the paresthesias in the affected head. So the moment you see this kind of the question is related to the radial nerve injury and how specifically you will locate that what is the level of the radial nerve injury in this case. So for that you have to understand the very basic anatomy, that if the radial nerve is injured in between origin and the spiral groove, so this is known by the name of very high radial nerve injury, and there are going to be the features of loss of extension of the elbow, there will be loss of extension of the wrist, and there will be loss of extension of the metacarpophalangeal joint. Plus, there is going to be a sensory loss, and or what is the specific radial sensory area? It is the first web space of hand. Another one is that if the radial nerve is injured in between the spiral groove, means at the level of the spiral groove all the way up to the level of the brachioradialis origin, so in that case there is going to be a loss of extension of the wrist and metacarpophalangeal joint, because there will be no loss of extension to the elbow. Why? Because the nerve to the triceps has already been given above the level of the spiral groove. The extension of the elbow is preserved. Plus, there is going to be a sensory loss in the first dorsal web space of hand. And this type of nerve injury to the radial nerve is known as high radial nerve injury. And then finally, if the radial nerve is injured at or around the level of the elbow, that means from the brachioradialis origin down, then in that case, as it is very clearly evident from the image also, that radial nerve, it divides into two of its branches. One, the posterior interosseous nerve, and the other one is the superficial radial nerve. Now you see, the posterior interosseous nerve is a pure motor branch to the radial nerve. That means if in case there is an injury to the posterior interosseous nerve, then there will be no sensory loss. What might happen in case of low radial nerve injury, which happens around the elbow? So there are two possibilities. One possibility is injury to the common radial nerve. That means just above the level of the branching. In that case, there will be a motor loss, which will be loss of metacarpophalangeal joint extension only. Why? Branches to the wrist extensors are already being provided. Plus, there is going to be a sensory loss. On the other hand, if there is a specific injury to the posterior interosseous nerve, then in that case, because it is a pure motor nerve without any sensory fibers, so there will be only motor loss. That means there will be only metacarpophalangeal joint extension loss without any loss of sensation. Now, if you go back to the question and read it properly, like he denies any sensory loss or paresthesia in the affected hand. That means there is a weakness in the metacarpophalangeal joint extension, but there is no sensory loss. In that case, the answer for that question is the posterior interosseous nerve injury. Next is a 42-year-old male carpenter presents to the neurology clinic with the complaints of progressive weakness in the right hand over the past 3 months. There is a difficulty in gripping the objects, frequently drop the tool, and experiences numbness and tingling in the little finger and the medial aspect of the ring finger. Now, whenever you see the little, that means the medial most finger involvement, and adjacent, that means ring finger involvement, then you have to think of the ulnar nerve. Now, he denies any recent trauma but reports that his symptoms worsens after prolonged elbow flexion or resting his arm on the hard surfaces. This is how you have identified that possibly the question is asked in relation to the ulnar nerve. All you have to do is further consolidate your answer on the basis of the findings provided below. You see, in order to understand about the ulnar nerve, it is essential for you to understand the intrinsic muscles of the hand. All of us are aware of the fact that there are in total 20 intrinsic muscles which are arranged in 5 groups. What are those 5 groups? The thenar, two interossei, hypothenar, and the lumbricals. So if we look at the thenar muscles, then the muscles are flexor pollicis brevis, the abductor pollicis brevis, the opponens pollicis brevis. All of them are supplied by the median nerve, but the adductor pollicis is supplied by the ulnar nerve. On the other hand, if we look at the hypothenar muscles, then all the hypothenar muscles are supplied by the ulnar nerve. You see the interossei, which can be divided into 4 palmar and 4 dorsal, all of them are supplied by the ulnar nerve. And if you look at the lumbricals, which can be categorized theoretically into 2 medial and 2 lateral, so 2 lateral are supplied by the median nerve, while the 2 medial are supplied by the ulnar nerve. Although the first lumbrical is rudimentary, so practically lumbricals are majority of them supplied by the ulnar nerve. So as you can very clearly find it out that majority of the intrinsic muscles of the hand, that means around 15 muscles of the hand out of 20 are supplied by the ulnar nerve. And that is the reason why understanding the anatomy of the ulnar nerve is extremely, extremely important. All of us have to remember the fact that what are the functions of the thenar muscle? It is written in their names. What are the functions of the hypothenar muscle? These are written in their name, although they are not practically feasible. What are the functions of the interossei? All of you know that palmar interossei is responsible for adduction of the fingers, while dorsal interossei is responsible for abduction of the fingers. The lumbricals are having a function of bringing flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. So these are the functions of the intrinsic muscles of the hand along with the nerve supply. Now, in case of ulnar nerve, all the adduction functions of the finger is the function of the palmar interossei. It is the function of the ulnar nerve. If you ask a patient to forcefully adduct all the fingers on the table, while the little finger, it sways away, it moves away. So this is the feature of the Wartenberg sign. Now, what happens in Wartenberg sign? You ask a patient to adduct all the fingers while keeping the hand flat on the table. The little finger remains abducted due to the weakness of the palmar interossei and unopposed action of extensor digiti minimi. Another one is then when you ask a patient to hold a book in between the adducted thumb and rest of the fingers, and as an examiner you try to pull this back, that one of the thinner muscle, that is adductor pollicis, is supplied by the ulnar nerve. So you are testing the ulnar nerve integrity of the thumb. So if you can easily pull this book out, so this is known as book test positive. Now, patient tries to hold the paper or the book tightly, so he will modify the test on his own self. So because he cannot hold the book by adduction, so he will try to hold the book by flexion at the metacarpophalangeal joint. That means he is bringing another muscle into action, and that is achieved, or that is known by the name of Froment sign. Ask the patient to grasp a sheet of paper between the thumb and the index finger while the examiner tries to pull it away. Now, the patient compensates by flexing the thumb interphalangeal joint due to weakness of the adductor pollicis, as you know, which is supplied by the ulnar nerve, causing overactivity of the flexor pollicis longus muscle, which is supplied by the median nerve. So, if median nerve is functional, you have asked the patient to perform book test while he is modifying it to a Froment test. Another one is the dorsal interossei. You know, dorsal interossei, the major function is abduction, and you ask the patient to abduct all the fingers while you are providing resistance. Now, if you can, as an examiner, feel the resistance, that means abduction is normal. But if you cannot feel the resistance, that means the dorsal interossei are not functional. And this is known by the name of EGAWA test. And finally is the card test. Here also you are testing the integrity of the palmar interossei by placing the card in between the two fingers. As an examiner, you are asking to hold the card while I am trying to pull this out. If the examiner can easily pull this card out, that means the palmar interossei are not functional. That this is again indicative of ulnar nerve injury, and this is known by the name of card test. And one thing that you are already aware of, that if there is a ulnar nerve injury, then there will be a loss of lumbrical function, particularly the medial two lumbricals, and as a result of which there will be a loss of flexion of the metacarpophalangeal joint, while there will be a loss of extension of the interphalangeal joint. So it will result in the claw hand. How is it identified? Extension at the metacarpophalangeal and flexion of the interphalangeal joint. Ulnar nerve related tests have to be integrated by the understanding of the intrinsic muscles of the hand anatomy. And now you can go back to the question and answer it very easily, that on examination, when asked to hold the book with the thumb and the fingers, the examiner could easily pull it back. That means the adductor muscle function of the thumb is not there. The patient was not able to extend the medial two fingers completely. This is the feature of the claw hand. And when asked to hold the bunch of the papers in between the two fingers, it was also weak. That means the card test was also positive. So what is the answer for this question? It is ulnar nerve compression. Now is the time to decide that where exactly sensory testing reveals the diminished sensation over the medial 1.5 fingers. So on this basis, you can say that the ulnar nerve is likely to be affected at the higher level, that is cubital tunnel, because of the loss of the sensations. Because had there been an involvement at the Guyon's canal, it would not have any loss of sensations. So hopefully the answer for this question is clear. Hopefully you have understood everything related to the ulnar nerve injuries. Coming on to the next question or the next topic itself. A 45-year-old female office worker presents with the complaints of numbness, tingling, and pain in her right hand, particularly in the thumb, index finger, and the middle finger. Index finger and the middle finger is affected. That means think of the median nerve. Now, her symptoms worsens at night. After prolonged typing, she also reports occasional weakness in her grip strength. On examination, there is a mild thinner muscle atrophy. Why is there a thinner muscle atrophy? As you can see that all the thinner muscles in the hand, except for the adductor pollicis brevis, all of them are supplied by the median nerve. So there has to be a thinner muscle atrophy in case of median nerve injury. A clinical test is performed where the patient is asked to flex both the wrists to 90 degrees. Now this maneuver reproduces her symptoms, confirming the diagnosis. So which of the following clinical test was performed? So before we come to the clinical test, what is the topic for which the question is asked for? Answer is carpal tunnel syndrome. Now you have already identified this. Now, what all you have to remember related to the median nerve injury, because all of you know that the carpal tunnel syndrome is associated with the median nerve injury. This is something which we are not going to talk about. Under the flexor retinaculum, it is affected. What are going to be the clinical features like? But in NEET PG examination, particularly what they used to ask are the tests. So one of the tests is the Fallon test, which you already are aware of, that the patient flexes both the wrist to 90 degree against each other and hold it for 30 to 60 seconds. It is a provocative test. So it is most commonly used test for CTS, and it is positive in about 70 to 80% of the cases. Exactly opposite is the reverse Fallon test, where there is an extension and the patient is asked to hold the wrist against each other. Another one is the Darkan's test, which has been asked multiple of the time, and it is by the application of the manual pressure over the carpal tunnel for 30 to 60 seconds. This is again a provocative test where there will be an increase in the pain, numbness, or tingling in the median nerve distribution, and it is considered to be the most sensitive test for the carpal tunnel syndrome. Then there is a hand elevation test, which is highly sensitive for the carpal tunnel syndrome, which is achieved by raising both the hands above the head for the period of around 120 seconds. This tourniquet test, which is also known by the name of Gilead test, is the direct application of the tourniquet over to the area of the wrist, and numbness and tingling in the median nerve distribution. It suggests median nerve compression or ischemia. So hopefully you have understood everything related to the tests which are very, very frequently asked in relation to this median nerve. Now, you know that there will be a ape thumb deformity. Why ape thumb deformity? Because all the muscles in the thenar group are supplied by median nerve except the adductor pollicis. So when there is a injury to the median nerve, then all the muscles are paralyzed except the adductor pollicis. So there will be an unopposed action of the adductor to the thumb, leading to partial adduction of the thumb with the thenar atrophy. It appears like the thumb of the ape, known by the name of ape thumb deformity. Another feature of the median nerve injury is the pen test. And what exactly are you doing in the pen test is the testing the abduction of the thumb, because abduction of the thumb is a function of abductor pollicis muscle, which is supplied by the median nerve. Another feature of the median nerve injury is the pointing index. When you are asked to make a fist out of your hand, then the index finger remains extended. It remains pointing because both the flexor digitorum profundus and the flexor digitorum superficialis tendon, which are dedicated to the index finger, are supplied by the median nerve. And as a result of which, in case of a median nerve injury, all the fingers would be flexed to some extent except the index finger, which remains pointing towards you. That is the reason why it is called by the name of pointing index. So these are the features of the median nerve that you have to identify. And coming back to the question, they were asking about that what is the name of the test which was performed, and answer for that question is straightforward, that is Fallon's test. And in the lower limb, most commonly asked injury is in relation to the sciatic nerve and the common peroneal nerve. You see, the course of the sciatic nerve, as you are very well aware, that it lies just posterior to the hip joint, posterior to the ischial tuberosity, and this is one site where this could be affected. How? One is the posterior dislocations of the hip joint. Now, if this hip joint it dislocates posteriorly, it might cause impingement to the sciatic nerve. Another one is the fractures of the acetabulum, because in case of comminuted fractures of the acetabulum, there might be impingement of this sciatic. And finally is the surgical one, that is iatrogenic injury, particularly in the Cocker-Langenbach posterior approach to the hip joint, where you are fixing the acetabular fractures or you are going for the replacement of the hip. So it is very common. So these are the three reasons for the sciatic nerve injury. What is going to be the outcome? There is going to be a loss of any foot movement. That means both dorsiflexion and plantar flexion would be lost in case of a sciatic nerve injury. Then this sciatic nerve, at the level of the popliteal fossa, it divides into the common peroneal nerve and the tibial nerve. Now this common peroneal nerve, as you know, it further divides into the deep peroneal and superficial peroneal, and then this deep peroneal nerve is responsible for supplying the tibialis anterior. And you know, tibialis anterior is the major dorsiflexor of the ankle joint. Now if tibialis anterior is affected, then there will be a loss of ankle dorsiflexion, and this loss of ankle dorsiflexion is known by the name of foot drop. There has been multiple questions which are asked in relation to this, like if the patient is presenting to you with this kind of an injury where it is associated with the posterior dislocation of the hip, and then they ask you what is the name of the nerve which is likely to be injured related to the x-ray. Similarly, they have asked this question also multiple times, that if there is a fracture over here in this region, and this region is significant. Why? Because fractures in the proximal fibula might result in injury to the common peroneal nerve. There will be a loss of tibialis anterior functions, leading to inability to dorsiflex the ankle, which is also known by the name of foot drop. So you have seen these kind of the questions multiple of the times. Then finally, although this question has not yet been asked, but we expect this question to be asked, where the brachial plexus injuries are categorized into two, which is preganglionic or postganglionic. These type of injuries are significantly important as far as practical considerations are concerned, because in case of a patient who is having this preganglionic type of injury, there is no regeneration possible. So it is associated with a poor prognosis, while there is a potential for regeneration in postganglionic injury. So you should be able to identify that whether the injury is preganglionic or postganglionic on the clinical basis. So you see what happens in preganglionic. It is proximal to the dorsal root ganglion, as we have just seen, while it is distal to the dorsal root ganglion. The cause is high velocity trauma, while in case of postganglionic, it could be a clavicular fracture, penetrating injury, the shoulder dislocations. The type of damage that happens to the nerve is particularly the root avulsion. That means nerve root is pulled out of the spinal cord, while there could be a rupture, neuropraxia, compression injuries to the postganglionic nerve. As far as surgical repair is concerned, it requires nerve graft or nerve transfer, because direct repair is not possible. While the direct repair is a possibility in case of postganglionic injury, sensory loss is permanent except for the heat withdrawal symptoms, because that circuit is getting completed peripherally. So withdrawal reflex is present. While sensory loss, it depends upon the severity and it may recover over a period of time. It is if it is postganglionic injury. As far as motor loss is concerned, there will be a complete motor paralysis. There will be complete paralysis of the muscle which are supplied by the affected root, while there will be weakness or paralysis depending upon the severity to the postganglionic injury. Now, preganglionic injuries are also identified when there is a paralysis of the central muscles like diaphragmatic muscles. The preganglionic injury is also identified if it is associated with the Horner syndrome, because it is suggestive of that the patient is having an injury which is nearer to the spinal cord. So although this question has not yet been asked, but there is always a possibility in future. Now we hope that session was helpful. All the best for your future examination. Keep shining, keep studying, keep doing your hard work, keep truthful to yourself. And if in case you do not want to miss any update, please join our Telegram group related to the NEET PG 2025. All the best for your future examinations.